This is the damage on the inner portion of the hip joint. The femoral head's below us, the hip socket or acetabulum is above us, and this is the acetabular labrum. This is the area that's frayed and torn. There's complete detachment right here where I'm probing, and this is caused by the CAM lesion. This is showing you the repair from the outside. So this is the suture that's repaired the labrum back to its normal attachment. And now this is the femoral neck. This is the very anterior or front femoral neck. We're under the hip capsule. We're now removing fibrocartilage from the area of the junction of the femoral head, which is to the right, and the femoral neck, which is to the left. And I'm using a radiofrequency probe device to remove fibrocartilage and just prepare the area for bone resection, which I'm going to do in a minute. This is bone resection. Now we're using a burr. This looks quite large. This burr looks quite large, but it's actually 5 millimeters in diameter. So I'm removing about 2-3 millimeters of bone from the area this is the very anterior or front femoral neck, and then I'm about to go along the more anterior lateral or side of the femoral neck, head neck junction. And I'm just removing enough, not too much, but enough so that when this patient moves into a flexed or bent position at the hip, this area of femoral neck does not come into contact with the area that was damaged and repaired or earlier I showed you. This is now extending more along the outer part of the femoral head neck junction, lateral we call it. I'm just going through the hard layer of bone into the more softer cancellous layer, and just removing enough to relieve the impingement, but not too much that we over weaken the femoral neck. You can see synovium is folded in. I try to remove as little, I try to make an opening as small as possible in the femoral the hip capsule to gain access to the femoral neck, to minimize any destabilizing effect. If I do a larger capsulotomy, I'll actually repair the capsule, but here, because I'm removing such a small area of capsule, it would not be necessary. There are other considerations as well that make me decide whether to repair the capsule or not. So this now again is getting more lateral, head neck junction, trying to make it contour it so it's nice and smooth, and has a normal, what we call offset or indentation. This is basically, again, to relieve any impinging or rubbing that would happen in the more lateral part of the hip joint. Again, so I'm making the normal junction right at the middle of the picture here, and then removing bone further distally down the femoral neck to give it a nice smooth contour. So now I'm just finishing things up. I've come around the lateral, just posterior lateral. There is blood supply to the femoral head just past this, about 1 centimeter, 2 centimeters just past where I just showed you. This is more anterior now, and I'm basically trying to give this a nice smooth contour, what we call a concavity or indentation, offset, smooth transition then from the area that I started with right at the head neck junction, and then heading more distally to the left down the femoral neck, going all the way around. The patient's leg is in an extended position. I start this femoral neck resection with the hip flexed about 20-30 degrees, and here this is an important very lateral, posterior lateral corner here that you really have to make sure you get to. It's not as easy to see. I have the leg in about 10-20 degrees internal rotation to allow access to this. And here you can see the fraying from previous impinging movements and motions, and I'm just trying to end my resection right where that fraying ends. Here I'm just taking off the loose edges. Just cleaning things up, making the transition nice and smooth, so as this patient goes into a flexed or bent position, things don't rub on the inner portion of the hip joint and the labrum and cause further damage. There you can see very anterior, anteromedial, under the capsule, and more lateral.